So what he's going to do here is he's going to go back into extension and just begin to get a very nice passive extension of the thoracic spine. Now, one of the things that you can do here is you can begin to engage the gluteals by having them bring their rear end up and maintain that position as they go into extension. Then the next thing that you can have them do, and once they become comfortable doing that thoracic spine extension, now we can have them go over to the side and do side bending over the ball. And he comes back and goes over to the other side. This is not something I usually do the first time with the patients because they're usually a little bit nervous. And so once they get more comfortable with the ball, then I start adding that component. Here's some examples of reactive stabilization exercises. So in this one, I'm going to have him hold that, and I'm going to give him lots of perturbations. And oftentimes the length of the treatment is dictated by the therapist's fatigue. PNF diagonals. So these are the PNF diagonals that you can use. And looking at pectoralis major and minor, you want to make sure that the scapula or the shoulders are relatively flat. He looks pretty good there. He doesn't have any tightness. Here's a way to stretch the latissimus dorsi in standing. Flatten the low back against the wall, arms together, externally rotated, and try to bring them up in front of you. Maintaining the pelvic tilt, elbows together, forearms supinated, and raise overhead. Then the next thing would be to look at doing a posterior capsule stretch. So this is my pitcher who has a limited internal rotation, but he has a lot of external rotation. So what he's doing is he's going to be stretching down in this direction. This is a way to stretch the upper thoracic spine and to open up the chest wall. It's called the open book stretch. So you start on your side, rotate over, supine, extend the arms. It begins to engage the thoracic spine and lumbar spine. These are more exercise. I think I've already shown you this. But with this one, I want you to look at his leg as I bring him up into the test for the lower trapezius. He tries to really engage everything. So you can see that when you do a lot of these exercises, you're not just doing the glenohumeral or the axioscapular muscles, but it really is going to also pull everything else in terms of thoracolumbar spine. Stabilized tubing exercise. He's not in very good posture here. So what he's going to do is he's going to stabilize the scapula, stabilize the spine. He's going to do a row, and then come back, and then let it go. Superman flies. These are a variation. You can do the prone T to Y exercises over the ball. You really want to make sure he hasn't done a very good job of this. You want to make sure that the legs are fully extended, and you can see that his legs are externally rotated. I want to have those legs in neutral, and I want to have a very stable pelvic base. I also don't want to see a lot of extra hyperextension in the lumbar spine. Reach, roll, and lift. This is a variation on the lower trapezius exercise. You have the person roll the ball forward and then do the lift off from that. So you're starting now to work on a mobile base. This is someone who is going to then also look at balance. So he's got his legs up in the air and he's going to lift up off the ball. You can also add PNF diagonals to that. And this is a Swiss ball clap, and so this is a very advanced exercise that's going to facilitate impact loading, reaction time, and reactive proprioception. This is a way that you can also stabilize, use the pelvis to integrate that with the PNF diagonals. Using the foam rollers for some of these exercises. Now, instead of being on a stable base of the treatment table, you do these on the foam roller, and now that adds an unstable base, and they have to really generate a lot more stability dynamically. Then we can also have them lifting the ball overhead, pushing the ball up. They can also roll the ball out and back in the lower left or lower right-hand corner. Then we have a body blade, which actually then you can use vibration with the body blade to stimulate the activity of the muscle spindle to help with stabilization. And so you use functional positions. You can either do it with a two-handed grip or a one-handed grip. Reach backs are just like the supine open book exercises, but now I'm going to add a lot of trunk rotation into that. And here's another version of doing a serratus press. So they do a press up and then they do a little plus at the end. Helicopter lunges. Again, now I'm adding a lot more dynamic stability. I'm having to do a lot more balancing with the lower extremities while I'm superimposing upper extremity movement and trunk rotation. And then I can break apart the skill where I basically go back into the turn and grab. So the part of the skill that I'm reaching for is from neutral to extension. And the rest of that skill is going to be to bring it forward. But I'm just working at that point on that first component. So that's an example of pulling that skill apart and then rebuilding it. Doing exercises on unstable surfaces like this Bosu ball or on a stepper. You put your hands on a stepper and you're going to be pressing it up and down. Now the other thing is that we're experts on exercises. This is in a weight room in a major Division I university, and it's from the website, and they happen to be in the same athletic conference as the University of Virginia, but I won't say who this was. It was not my alma mater. And he's instructing this person to do forward raises in maximum internal rotation with a weight, with probably 7-pound weight. Now the maximum that you should ever do with a supraspinatus exercise is 5 to 7 pounds. What would you recommend? Would you say that this exercise is beneficial or not? Anybody? No. Well, I guess I gave you asked a leading question, right? So it's not beneficial because you're in maximum internal rotation. You're bringing them up into an impingement position. And I actually wrote to my colleague there, and I said, you're actually reproducing one of the clinical tests for an impingement syndrome. And a couple days after I sent that email, the picture was no longer there. So I want to talk a little bit just very quickly about taping. I know that there's been some questions about taping. I use a lot of different types of tape. The evidence is variable. Most of it has to do with the fact that we're probably affecting proprioception. So traditional tape basically worked on the idea of restricting motion, creating a flexible cast. But some of the research that we did in the early 90s in our lab was looking at standard ankle taping, bracing on tailored tilt. This is we have a type of tape in the U.S. called duct tape, and it's used for everything under the sun. And I've actually had people come in and say, well, I duct taped my shoulder, and this is an example of a very creative use of duct tape. So it can be used, again, as a flexible cast, and we actually did a study where we looked at doing this standard taping versus using a brace. And we looked at the tailored tilt as an index of ankle stability, and we found out that with exercise, after about 15 minutes, you really didn't have any difference between the tape or the brace. Neither one of them was particularly effective in limiting motion because the tailored tilt was still present. It can be used to reduce inflammation or edema in a traditional way that we use in sports medicine by working to affect mechanical compression. There's a kinesiology type of tape which works on lymphedema by assisting the lymphatic system drainage. And so that tape is not designed for compression. In fact, it wants the opposite effect. One of the things that we did in a subsequent study with another set of graduate students was to look at a case study of an MRI of a patient with bilateral patellofemoral problems, and we evaluated and taped one of the knees for correcting the patellar position, and the other one we did not. And we found that there was really no difference in the orientation of the patella when we used the merchant X-ray. And so that really kind of led us to think that we really are not affecting anything in terms of moving any bones or anything like that, but it really works more with proprioception. One of my colleagues at Marquette University then took that idea a little bit further. He just took one piece of tape. This is a forced platform, and what he did was measure the reaction time when he put the person into a tilt. And so what he found was that just that one strip of tape actually was very helpful with proprioception. I've also done a lot of work with equine rehabilitation, and this is a use of duct tape where it's appropriate. And so this was done by Narelle Stubbs, who's a colleague of mine in Australia, and we've done some work together in terms of facilitating motion in horses that have been injured. And then finally, you can also use it to rest muscle and injured tissue to try to reduce pain. And then finally, what I'd like to do is show you very quickly, there were some questions about how would you use this for edema. And so this is where I think this type of tape is very helpful. There has been actually some evidence that it does help with reducing the edema. And in some cases, there's been a small study where they applied it in the operating room for the first 5 to 7 post-op days, and they showed reduced volumetric and circumferential measurements after 48 hours. So this is an example of how it's used in the leg. Now, since we're in a shoulder course, or I'm talking about the shoulder, it can be used for lymphedema management, so you place the base of the tails in areas where you've got the major lymphatic ducts. And then for post-mastectomy lymphedema, I would put the base over the coracoid, and then I would put the tails that would go over the region of the pectoralis major. So just a few things about clinical prediction rules. That's been a very hot topic in physical therapy, but we have to have a few cautions about that. And some of the study designs can't tell the difference between predictors of response to treatment and predictors of outcome. And there's a lot of variability, secondly, of clinician estimation, and you have to really understand CPR. The clinicians have to be exposed to that. And so finally, I would like to say thank you. You've been very attentive. And the Japanese on the right is a sign for question and answer. I can't read kanji. But Florence Kendall really, as I said, influenced me, and I hope that we can leave this conference with this idea. If you and your colleagues each have €1 or one of whatever your currency is here, I don't know, and you share your euros with one another, you still have €1 or one coin. If you share an idea, one with the other, each person will have 2 ideas. Go now and share your ideas with your colleagues. And so that is from one of my favorite mentors, Florence Kendall. So thank you very much for your kind attention.
Thank you, Dr. Christine, for your presentation. We're going to start taking the questions. Now, we would like, please, all of those who would like to ask questions, please state your name and where do you work, and state your question clearly. And who has questions? Okay, we're going to start with the left side. Just state your name and where you work.
My name is Abdullah. I'm a manipulative physiotherapist clinic